And we'll do the Q&A at the end, Monica.
Yes, I left plenty of time. I would love to hear people's thoughts. So thank you.
Great, thank you. Good morning, good afternoon, good evening for some folks. We're going to just wait a couple more minutes as we get a quorum, but thank you for attending this antiretroviral prevention call. Hello, everyone. We'll give this just about another minute while we wait for folks to join the Zoom. Good morning, good afternoon, good evening, everyone. I'm Ken Mayer from the Harvard CFAR, and I'm happy to welcome you to this antiretroviral prevention seminar series with my co-facilitator, Patrick Sullivan of the Emory University CFAR. We couldn't be happier than today to have Dr. Monica Lewinsky. Dr. Monica Lewinsky, that was amazing. Boy, free association. Dr. Monica Gandhi of UCSF joining us today. That's the first. Yeah, thank you, Jim.
Yeah, a long time ago.
Yeah. Funny how the brain works. Anyway, Dr. Monica Gandhi of UCSF, who's the director of their CFAR, as well as the director of Ward 86, the famous center for many important insights about how we take care of people living with HIV and at risk for HIV in the Bay Area. Dr. Gandhi has distinguished herself not only recently in her work on COVID-19, but over many years trying to think about how we can best provide antiretrovirals for people who have experienced various social adversities. And in addition to that, she's also done very innovative work on monitoring antiretroviral adherence for both people on antiretrovirals who are living with HIV, as well as those at risk for HIV using pre-exposure prophylaxis. So without further ado, and without any more malapropisms, Monica, thank you for being here today.
Thank you very much for having me. And I'm going to really talk about not just point of care methods, but kind of go over the pharmacologic metric adherence literature, the entire thing, so that we can get up to speed on all of this. So we'll talk just why we would want adherence metrics in ART and PrEP, the history of pharmacologic metrics. There's actually a very clear event that led to pharmacologic metrics becoming big and becoming something that was important. Development of the urine tenofovir assay, which is a point of care assay. And I want to bring in dolutegravir resistance today because I think it's something that people are starting to think about over the last 6 months, and then why that would be relevant to the urine tenofovir assay. So just to start with adherence, we should not feel in HIV that we're the only ones, because the World Health Organization has declared that more people worldwide would benefit from efforts to improve medication adherence than from the development of new medical treatments. And non-adherence has been called America's other drug problem. And essentially, in the fields of cardiovascular disease or diabetes, only 50% of Americans are adherent to their therapy. And people stop their statins. It's hard to take medications every single day when you feel okay. And essentially, drugs don't work in patients who don't take them. And so what do we know about adherence to antiretroviral therapy? It's variable. There are places which are doing great. There's a 95% virologic suppression rate in many low and middle income countries, Kenya, Uganda. But here in the United States, we have definitely fallen. The medical monitoring report as of August 2023 shows that our overall rates of virologic suppression are lower and than we had hoped at this time. And it has to do partially also with setbacks during the pandemic. We're at about a 59% sustained virologic suppression rate. Probably across the planet, we're at about a 71% virologic suppression rate for those on antiretroviral therapy. And that, remember, the UNAIDS statistics cannot actually include those countries that don't do viral load monitoring regularly. So that could be an underestimate, possibly. And the barriers to ART adherence, as shown on the right, are very variable, and they depend on where you live in the world. And they could be, I would say, in the urban centers like Boston, like San Francisco, I would think, and New York, I think that substance use, housing insecurity, and mental health concerns are the increasingly major reasons for problems taking antiretroviral therapy or PrEP. And this was a large meta-analysis of PrEP adherence. This was a systematic review performed a couple of years ago, and 41% of those who were started on PrEP, 41% of those discontinued, and even those who stayed on PrEP, suboptimal adherence was there for about 38% patients. So definitely, it's also likely a bigger issue in pre-exposure prophylaxis, so we have to work on adherence. And one other final reason to work on adherence in the prevention world is, of course, the U=U guidance. This was very interesting. The WHO changed their cutoffs for undetectable equals untransmittable, or at least they stressed that the cutoff at the July 2023 IAS meeting was less than 1,000. That is actually their cutoff for virologic suppression. There was some criticism around that because the big cohort studies showed that viral load less than 200. It's what's really associated with undetectable equals untransmittable, and the data between 200 and 1,000 is quite sparse. But at any rate, it really is important to say that there are multiple reasons why increasing adherence is important. So let's talk about the history of pharmacologic metrics up to adherence and why we would want a point of care metric. Well, I do think there was a distinguishing event that led to the advent of pharmacologic adherence metrics. Prior to that, how we measured adherence was just asking people. And that does work. That is the most common way that we ask how patients are taking drugs. But when I say it works, there is a certain bias, social desirability, and recall bias in presenting your rates of taking antiretroviral therapy, completely understandably. There were also sensor devices, electronic monitoring, other ways to look at how patients take their medications. But increasingly, we've had a focus for the last 12 years on pharmacologic metrics of adherence. And what was the sort of inciting event? I really think it was the FemPrep and the VOICE trials. These were two, of course, large trials that showed in young sexually active women that TDF-FTC-based PrEP had null efficacy after other trials, Partners PrEP and Iprex-Olay, had shown the effectiveness, the efficacy of PrEP. And it was important to know that in these trials, VOICE and FemPrep, self-reported adherence was over 90%. Return to pill counts was very high. But if plasma tenofovir levels were done in residual plasma of those who are on active product, tenofovir levels were less than 30%. So it really did show that it was adherence that was the concern in the VOICE and FemPrep trials, and it was the pharmacologic metric that led to the ability to interpret these trials properly. And so it was this, I think, this particular event that really launched the pharmacologic metric monitoring field. And of all of those other ways to measure adherence, I'm going to focus in on pharmacologic metrics for the rest of this talk. But I will say that, of course, again, there are pharmacy refills. There's, of course, virologic monitoring, viral load monitoring in the context of therapy. There's MEMS caps. There's directly observed therapy, which would be the best way to ask about adherence, but of course that's completely impractical. So I want to focus in on this aspect of objective adherence monitoring. And the mantra here would be what gets measured gets managed, because measuring it can empower you to intervene on it. So there are really 4 biomatrices that are used most commonly in at least up to this point, and then we're going to get to urine as the other focus of this talk. Prior to the urine point of care metric, it was really measuring drug levels in plasma, which would be the shortest metric of drug adherence, because plasma levels of tenofovir reflects about 4 to 7 days of drug taking. PBMCs were used a lot in IPREX and IPEX-Olay, but they're a little harder to collect, so fallen off. Tenofovir diphosphate levels in dried blood spots measure a longer time of adherence. Why is that? Because tenofovir as a product is actually intracellularly metabolized. And so its diphosphate component is a longer term metric. And then tenofovir levels in hair, depending on how long of the hair sample that you measure, is the longest of all. The thing about plasma metrics is they have pros in the sense that research settings, like I just showed you in FemPrep and VOICE, have plasma collected, and so does clinical care. And this really plasma levels of tenofovir were the most important predictor of efficacy in all of the PrEP trials. The cons are that they have a shorter window of exposure. There's intra-individual variability day by day of a plasma level. And you really need to know the time of the last dose taken to interpret a plasma level properly. And they are subject to white coat adherence, but we'll get into that where you take your medications prior to a research or clinic appointment. Drug levels in PBMCs, as I've said, are a little more difficult because they're harder to process. So really it's tenofovir diphosphate levels or FTC, emtricitabine triphosphate levels in dried blood spots that have been used in multiple trials and demonstration projects. Dr. Pete Anderson does a lot of this at the University of Colorado. Some cons in that they must be standardized to hemoglobin counts, and we've seen lower thresholds likely in African women who have lower hemoglobin counts, but a lot of pros in terms of being able to use the have the dried blood spot be at room temperature for a while, and the longer term metric of adherence. And then drug levels in hair, we actually are the lab that have developed this the most, and it's really tenofovir levels in hair for PrEP and ART. And the idea would be that plasma levels go up and down each day, but a hair level sort of evens out that exposure. And in both PrEP and ART, this was one of the first studies in antiretroviral treatment. We've shown that hair levels of drugs are the strongest independent predictor of virologic response. But what is the major limitation of everything that I've mentioned? Plasma levels, FTC triphosphate, tenofovir diphosphate and DBS, and hair levels. One major limitation is that they all use liquid chromatography, tandem mass spectrometry. All of us who work in the pharmacologic adherence monitoring field have these machines in our laboratories, and they're very powerful metrics, but it is hard to have a point of care metric using a spectrometry-based machine. It takes lab processing, it takes time, and we haven't been able to get a point of care metric using LC-MS. So that's why I would turn to why a point of care test to target and also enhance adherence interventions would be so important. At the time of the clinic visit, could you have a point of care test that tells you yes, no? Are you taking the tenofovir example? And tenofovir, of course, would be an important drug just because it is the drug that's used in PrEP, and it's also the drug that's used in antiretroviral therapy. And so, so I do want to say that the reason that you'd want a point of care metric is you want something right there at the clinic level. You could do two-way text messaging, you could do peer support, pillboxes, motivational interviewing, provider counseling, slot patients into differentiated care delivery. There's a usefulness to having a point of care metric. But the thing about having a point of care metric is that you need an antibody test. To do liquid chromatography tandem mass spec is going to be hard to do at the point of care. And what you really need to do is develop a highly selective antibody for tenofovir in the urine so that you have a point of care test like an antibody against HCG, for example, for pregnancy testing, an antibody against SARS-CoV-2 antigen for rapid testing for COVID. So you really need a very selective, you need to develop a selective antibody for tenofovir. And that's the only way to get to a real point of care metric. And so let's turn to those studies. That's the next point of the talk, is the development of the urine tenofovir assay and what studies have actually examined the urine point of care tenofovir assay. So other groups have done this, but our UCSF group has developed a highly selective antibody for tenofovir, but it took us a number of years. We started actually a collaboration with what was called Alere Rapid Diagnostics in 2015. Usually this has to be done in conjunction with a company, because to make the point of care lateral flow assays does require company input. So we scrutinized the tenofovir molecule. We said, what are the parts of it that look really different than the endogenous nucleoside in our body that tenofovir resembles, which is adenosine, and then found epitopes of tenofovir, created little antigens, injected those into rabbits, spent time, kept them looking for an antibody, and finally an antibody was developed that was very specific for tenofovir. We did a lot of developmental work. These are the papers that we've published, looking at validating the tenofovir antibody. We wanted to make sure that it was highly specific to tenofovir. We didn't want it to pick up any adenosine or any endogenous nucleotides. And indeed, the false positive rate of our selective antibody is 0, so that you won't be having false positives. We compared the ELISA, which is a way of quantifying antibody-based detection of a drug, to the gold standard of liquid chromatography tandem mass spec in our laboratory. And these were all the validation and development and validation papers that we ended up submitting for regulatory approval to the FDA, for example, to perform subsequent studies. So this is what the lateral flow assay looks like. It looks exactly like a pregnancy test or a SARS-CoV-2 test. It's really now packaged into a little strip test. This is a prototype. It hasn't been marketed yet. We're still using the urine tenofovir test in the context of studies, of which some of them I will tell you about now. One of the first studies we did is look back at time, and Partners Prep had collected urine because were looking at urine for creatinine monitoring, and so had IPREX-LA and another study in PrEP done in transgender women. And so we were able to show that having a negative urine for tenofovir in the past predicted future HIV infection or seroconversion on the PrEP. So those were some of the first papers that we published. And then I think this is the most important study that we've looked at. This was a study done in conjunction with the CDC in Namibia. And these were in the context of clinics where the virologic suppression rate was not as high as we wanted it to be. And so essentially, this is a pre and post interventional design where over 200 people living with HIV were enrolled who had virologic failure on tenofovir, lamivudine, and dolutegravir, TLD, the standard of therapy. Everyone started with a 0% virologic suppression rate. And we actually showed them the urine test, did the urine test, monitored for urine tenofovir, showed them the urine test, and did counseling based on that visually accessible test of the urine test. We were able within 3 months to get the virologic suppression rate up to 87%. And by 9 months, the virologic suppression rate was 92%. And this seems to be sustainable in this pre and post intervention design. Also, we did acceptability and feasibility surveys. 86% of participants and 91% of providers wanted this test in clinical care, especially the providers said it was hard to do enhanced adherence counseling in a general, non-specific way, showing patients in a visually accessible and supportive manner. The urine tenofovir test made the counseling more specific and made the counseling more effective. And so it was really this pre and post adherence intervention that's led us to the next step of going to do a randomized trial. Now, we also have some other publications and examinations. Some of these collaborations are there at the Harvard CFAR, but this was in our Ward 86 pop-up clinic. These are patients who all have housing instability, and we just collected their urine and then saw in the context of virologic suppression if it predicted later virologic suppression. And yes, having a low urine tenofovir level provided an adjusted odds ratio of 6 times of future virologic failure. So it looks like it can predict future virologic suppression. And then I think this is really important to get in the topic of integrase inhibitor resistance in low and middle income countries. These are 2 studies, one done in conjunction with Mark Seidner and Suzanne Miklowski at the Harvard site, CFAR, and that was done in South Africa. And then we did another study, that was done in Uganda, and we did another study in South Africa. But essentially, the question was, what is the worst state of being if you look at that table down here? If you have a high viral load and low adherence, that's an adherence problem. If you have a high viral load and high adherence, especially with efavirenz, that really could indicate resistance. You're taking your drug, but the reason the viral load is high is because there's resistance. Having a low viral load and low adherence just is saying, okay, you could get into trouble later. Let's talk about avoiding problems in the future. And then having, of course, a low viral load and high adherence is exactly the outcome we want. And so in both these studies in South Africa and Uganda, among those on efavirenz and having a high viral load, a low urine tenofovir was 100% sensitive in predicting major NNRTI and NRTI resistance. So the reason that's important is you could be taking your drug every day, but again, it's the resistance, not adherence, that's leading to the problem. And so we have looked at dolutegravir. The urine test predicts adherence, viremia, pharmacy refill data, for example, in Nigeria, but we really need a study to look at dolutegravir resistance in those with a positive urine tenofovir versus those with a negative urine tenofovir, and I'll explain why in the next set of slides. And then finally, before I get to the possible study designs and integrase inhibitor resistance and why the urine tenofovir could be helpful in an algorithm to look at dolutegravir resistance in low and middle income countries, I have to discuss the question of white coat adherence. What white coat adherence is the idea that short-term adherence metrics would improve prior to a clinic visit or prior to a research visit, because you know that monitoring is going to be occurring. Now, it's interesting to say that I told you that the plasma levels of tenofovir were really the most important metric to predict effectiveness and efficacy across both PrEP rollout projects and PrEP trials, respectively. And urine and plasma tenofovir levels strongly correlate. They're both short-term measures. But even in context, for example, in the VOICE study later on, where participants knew that monitoring was going to occur, the efficacy was really associated with tenofovir levels in plasma. So there's a question about whether white coat adherence is as big of a problem as we think. There are 2 other studies that seem to dispute that white coat adherence is acting on a large scale level. The study on the right was performed at the University of Colorado by Jose Castillo-Mencia under Pete Anderson's leadership as well. They were working together. And this was essentially taking patients who were failing therapy or who they wanted to work on adherence and looking at the correlation between tenofovir diphosphate levels in dried blood spots and emtricitabine triphosphate levels in dried blood spots. Actually, FTC triphosphate is a short-term metric, tenofovir diphosphate is a long-term metric. And even though participants knew that the dry blood spots were being collected for adherence monitoring, there was a very strong correlation between how you took your drug every day, long-term adherence, and how you took it leading up to the clinic visit, short-term adherence. And then a study that we performed on the left that was just recently published in AIDS looked at also the correlation between a short-term metric, urine tenofovir, and a long-term metric, tenofovir diphosphate levels in dried blood spots, and showed a very high correlation between those two, and a very high positive predictive value of urine tenofovir for tenofovir diphosphate levels in dried blood spots, even though, again, participants knew they were being monitored. So it'll be interesting to see how white coat adherence plays out, but at least these studies have not shown a major concern. So let's go to make a foray into integrase inhibitor resistance, and then come back to why potential designs of upcoming studies using the urine tenofovir assay, and then really open it up to a discussion with us all about possible study designs using a point of care metric for adherence. Now, the reason I want to talk about dolutegravir resistance worldwide is I feel like it's been coming up more recently over the last 6 months. The 30th annual Resistance and Treatment Strategies Workshop in Cape Town in September, it was really one of the major discussion points at that meeting. Though I was not involved in this, Dr. Mellors, John Mellors tells me there will be a theme discussion at CROI on resistance to dolutegravir. It's being discussed, and there's a surveillance. There's certainly surveillance going on at the CDC level and the World Health Organization level. And it's really, we're now 4 to 5 years into the rollout of TLD worldwide. Really was rolled out for men, as you know, in 2018, and for everyone in 2019. And the 3 major questions that are coming up are: what are the risk factors for dolutegravir resistance? Of course, what's the prevalence? How do you detect that cost effectively? And how to transition to a darunavir-based regimen when needed using a cost-efficient algorithm. So I want to summarize the data so far about what we know about dolutegravir resistance. This can't be comprehensive because I don't have, of course, access to all the dolutegravir resistant studies, including those being performed at the WHO. These are just ones that have been presented more recently, including at the Cape Town meeting. This was a publication that was this month in Lancet HIV. This was a collaborative study that looked at INSTI resistance data from 2 collaborations, the ART cohort collaboration IDEA and the UK collaborative HIV cohort. Mainly this is high-income settings, though South Africa was included in this cohort collaboratives. And it was really looking that all the participants, all the patients' genotypic data was performed on those who were on dolutegravir-based ART. And of course, by definition, they all had genotypic resistance testing performed. There were 599 individuals surveilled from May of 2013 to December 2021. A third of them had been exposed to first-generation integrase inhibitors, raltegravir. Again, all were on dolutegravir, and a certain percentage were on dolutegravir monotherapy, and some on dual therapy. And this study showed that most of these individuals were susceptible to dolutegravir, but there was about a 5% low, medium, or high level dolutegravir resistance rate. And that 5 to 6%, of course, translated across millions of people, does have an impact. It's not something to panic about. I think it's something to just monitor for and to be aware of and to start looking at. And so the risk factors, I think you will find these not unexpected. The risk factors were being on dolutegravir monotherapy, dolutegravir dual therapy, and importantly, having NRTI resistance in the backbone, because dolutegravir is not just first line for naive patients and wild type patients, but dolutegravir, because of a number of studies, is first line even in the setting of NRTI resistance. And what are the studies that have convinced us of that? Well, Sailing and Viking were 2 studies that were performed even prior to the approval of dolutegravir. And now we've had 4 major studies during the rollout of dolutegravir: Dawning, Nadia, Vicend, 2SD. All of them have been published except for Vicend. And they're really looking at dolutegravir with NRTI resistance. And in general, if you look at the outcome column, dolutegravir does well with NRTI resistance. So it certainly is still first and second line with NRTI resistance. Nothing to change in the world yet. But I think it's important to say that if you really drill down on these studies, these were really comparison studies between dolutegravir and boosted protease inhibitors. And the most important one is to look at is the Nadia study that compared dolutegravir with boosted darunavir ritonavir, which would be the protease inhibitor of choice if needed, that the patients who failed with in the dolutegravir arm, there was a certain level of development of dolutegravir resistance, INSTI resistance. 0 in the darunavir ritonavir arm failed with protease inhibitor resistance. So with time, over time, if you're using dolutegravir on the face of NRTI resistance, there is going to be a certain accumulation of dolutegravir resistance. Not a lot, it's probably where we are in the world, but again, something to be very, very aware of. This is data that the CDC presented in a webinar several weeks ago, and I think will likely be presented in public forums coming up. These are very specific studies in Mozambique, Malawi, Ukraine, and Uganda, mostly either clinic or laboratory-based studies, trying to look at the rate of dolutegravir resistance in these countries. I think the top one is important to note in Mozambique that this is a very specific population. It's those with treatment experience who has persistent virologic failure, likely representing a very difficult time taking it at all. And there was a pretty high rate of dolutegravir resistance in that study. But in Malawi, Ukraine, and Uganda, these rates of around 4 to 8%, I think, are coming up. Just like in the study that I just showed you, the cohort collaboration, 5%, probably something like 4 to 6% is a rate to think about. This was an important study that was shown at the 30th International Workshop on HIV drug resistance and treatment strategies in Cape Town. And the reason this is important, and it speaks to the urine point of care assay, is that you actually, if you don't take your drug at all, of course, as we all know, that leads to a wild type virus. But it's really the event of taking the drug, of taking TLD, for example, that will, especially often on, that can lead eventually to INSTI resistance. And this was a study done in South Africa where drug exposure was monitored to dolutegravir by liquid chromatography tandem mass spec. And dolutegravir resistance in patients with laboratory confirmed dolutegravir exposure increased from 2.7% in 2021 to actually 11.9% in 2022 for those who had confirmed dolutegravir exposure. So again, if you're taking the drug and you have a high viral load, that's really a concerning scenario for having dolutegravir resistance. And then other data that was shown at the Cape Town meeting came out of the Uganda ART program, which has a very high virologic suppression rate. So these are really the samples that are sent to laboratories for genotypic resistance testing. So by definition, there's failure. And you could see that major dolutegravir resistance mutations were detected in 7.1% of children and in 4.4% of adults. So I think the major risk factors for dolutegravir resistance emerging to date are likely having an NRTI resistant treatment experience in the background with dolutegravir, being on dolutegravir mono or dual therapy, children having now being on dolutegravir versus the Odyssey trial may have higher rates of dolutegravir resistance. And I think this last one speaks to our final topic about how to use the urine assay. Having dolutegravir exposure, actually having a high viral load and having drug in your system is likely to be associated with resistance more than having a high viral load and having no drug in your system, which of course would be more associated with wild type virus. So this leads me to the final topic before we get into the discussion, which I'm really excited to have with you all, about upcoming studies using the urine tenofovir assay, including on what we just discussed with dolutegravir resistance worldwide. Now, adherence interventions have been tried. I mean, absolutely, there's wonderful studies on using different adherence interventions, nurse-delivered home visits, two-way SMS text messaging, motivational interviewing, cognitive behavioral therapy, using interactive computer-based adherence promotion, Peer mentoring has been really powerful. Adherence clubs, contingency management, providing actually incentives for adherence. There have been adherence interventions of getting motivation from the electronic monitoring, actually opening the pill and providing feedback to the individual. There have been some studies on drug level feedback of antiretroviral levels, but because these have been mostly using plasma or tenofovir diphosphate levels in dry blood spots, that drug level feedback can be delayed. I already told you about the Namibia CDC study, however, of drug level feedback being provided more immediately and showing that increase in virologic suppression rates in a pre and post design in Namibia, and then actually giving patients their drug and modified DOT. The thing about all these adherence interventions is that they're important, but they need to be scalable. They do need to be low cost and scalable to really have widespread application. Otherwise, they're going to be used in certain settings as they have been. And so could the urine test be more of a scalable intervention if it's cost effective? Once you've developed the antibody, these sorts of lateral flow assays can be made for very cheap, less than $2 a day, or a test. And so we just had put in a study to the NIH about an RCT that we want to conduct in South Africa, actually in rural regions in South Africa, where in the Eastern Cape, where the virologic suppression rate is around 62%, and it's not a pre and post design, but what we'd wanted to begin with, which is a randomized controlled study. Half of people with virologic failure being randomized to what the WHO recommends, which is enhanced adherence counseling to increase virologic suppression rates without the urine test, and then half, of course, with the counseling being performed with the urine test. And that got a favorable review, and so hopefully we'll be able to perform this RCT and really, through an RCT, show that if urine assays should be incorporated as a standard of care in enhanced adherence counseling. In terms of the resistance question, this is really the proposed study, and this is being discussed with PEPFAR and with the WHO, but the idea that we need to do surveillance. And I think countries like South Africa, Zimbabwe, India, Brazil are important studies to important country settings to look at, but it would be very simple. The question would be to assess resistance in those with high viral loads and a positive urine tenofovir assay indicating drug taking. Compare those to resistance rates in those with a high viral load and negative urine tenofovir assays. And the hope for that would be to come up with a more simple algorithm to prioritize patients for resistance testing using the urine tenofovir test, and fundamentally decide, of course, what we need to do with patients with dolutegravir resistance, which would be darunavir-based ART switch. And so I think this is something to discuss in different forums, including likely the ECTG and low and middle income countries, and with PEPFAR and WHO. And I think these kind of questions are under discussion. So in conclusion, pharmacologic metrics of adherence, I think, have been really important since FEMPREP and VOICE. There are really great research tools, including one that we've developed, which is tenofovir levels in hair, tenofovir diphosphate levels in dry blood spots, but they haven't been as accessible to point of care monitoring. A point of care urine tenofovir test has been developed, and at least in the pre and post interventional study does show promise to increase virologic suppression rates, but we need more studies to look at the urine assay's potential to increase adherence long-term and to formulate algorithms for dolutegravir resistance. And I'm really looking forward in the next, at the end of this talk, to hear your thoughts, study ideas from this group, and hear questions about this and comments and different study ideas. And so thank you so much for having me.
Wonderful. Thank you so much for your presentation. And we have some time for questions, which is great. I think we're going to start out. We're going to leave the chat is still open. So if people want to put questions in the chat or put up hands to get in line for questions, I can ask questions if they're in the chat, or I can call on folks. And I think we'll start out. We had a question in the chat from John Stanton. John, I don't know if you want to unmute and ask, or I can ask on your behalf if you're not in a good place to unmute. So I'll just go ahead and ask this then. I think you got to some of this, but the John's question, which is earlier in the presentation, was there we are. John, are you able to unmute?
Oh, yeah.
Yeah, go ahead.
Can you hear me?
Yeah.
Yeah. So my question was just relative to, how important you feel this, particularly with tenofovir, in high-income countries or resource-rich settings. So where we haven't seen a lot of INSTI resistance in the past, there's, I think, certainly been some feeling that, is this a good use of resources to test for tenofovir levels when you're most likely going to get an M184V and be able to use Biktarvy anyway? So do you think it is a good use? And do you see, with kind of the latter part of the presentation, pop-up INSTI resistance changing, that this may become more important?
I think these are great questions. Thank you so much. So, I didn't go over the data with background resistance rates and bictegravir susceptibility only because these large studies, Nadia, Dawning, 2SD, Vicend, have really been performed in low and middle income countries. It's more of a worldwide surveillance question, just because TLD is first line worldwide. But you're absolutely right that in US and Europe, bictegravir TAF FTC is first line worldwide. And though we don't have the great studies on top of a baseline resistance rate, there have been studies, for example, from Paul Sachs looking back at the 6 clinical trials for bictegravir, and if there's an M184V, very high rate of suppression, and that's likely true of other NRTI mutations, though again, it's a worldwide versus high-income setting. I don't think that in high-income settings, there is a utility to do urine tenofovir assays or plasma tenofovir assays. I think that luckily we also have the ability to perform resistance testing in these higher income settings. And so going straight to the resistance test, knowing that you can likely resuppress with a BIC TAF FTC, and certainly with darunavir based regimens, if there is significant integrase inhibitor resistance there. I think that that ability and that increased laboratory monitoring ability that we have means that the studies that I'm proposing really, I think, should be in low and middle income countries to figure out how to do surveillance more effectively, cost efficiently, to figure out dolutegravir resistance worldwide. We could just sequence large swaths of the population, but that hasn't been as cost effective. And so it's really the idea is, could we have a more cost-effective algorithm to figure out who to do resistance testing in? But I completely agree. We have BIC and darunavir in the settings of high-income countries.
That makes sense. And great presentation. Thank you.
Thank you.
Thanks. Aaron, are you able to unmute?
Yes, I am.
Right.
Thanks for a great presentation, Monica. It's Aaron Siegler at Emory University. So I just had a question about your thoughts on how we can integrate these pharmacological methods for adherence determination with non-daily dosing methods, which are more common in some parts of the world. Like in China, it's well over 2/3 of users are these non-daily users. And it's a tough thing to walk because you're somehow it's a pharmacological measure and a behavioral measure. It's like I think you have to integrate the two. I'm curious what your thoughts are on kind of best practices in this area, or what you guys have explored for this kind of challenging measurement issue.
I think this is a great question because it also applies to on-demand prep, and taking, for example, pre-exposure prophylaxis 4 times a week, and then what an interesting point about the stretching out medications and using not daily. So the thing about the urine tenofovir test, at least, is that it tells you if you've taken drug in the last 4 days. So it could actually still be useful for taking drug on a Wednesday and having a Friday monitoring test. At least in hair, we've modeled out the levels that are associated in hair with 2 doses a week, 4 doses a week, and 7 doses a week of tenofovir. So there's a more quantitative metric. But the thing about the urine tenofovir is it really is plus minus, it's a qualitative metric. And because it gives you whether you've taken drug in the last 4 days, I think it could still be useful in the scenario that you outline. So that's a really, really excellent question.
Great, thank you so much.
Thank you.
And did you have a question also?
Yeah, Monica, that was a wonderful talk. So thank you so much.
Thank you.
I'm curious if you would want to describe what the counseling entails that you do with your monitoring, and is it based on any behavioral science theories, or is it a more empiric process that you derive the counseling that's paired with the urine monitoring?
No, that's such a great question. Actually, we did do formative work prior to the Namibia study to work with participants about how to deliver counseling supportively. It is really based in motivational interviewing, and the way that we do it is everything has to be done should be done in a very supportive manner. It's very hard to take pills every day, especially in prep. So the way that we have very standard scripts where if, for example, in the face of non-virologic suppression, if you have a positive urine tenofovir test, it would be, great job. This is wonderful that it's in your system, still not virologically suppressed. So how can we help you take it more every day? How can I support you in that? If it's negative, it's hard, I absolutely recognize how hard it is. Lots of challenges to this. How can I help in this context with you being able to take these drugs every day? So it's very motivational. It's very supportive. It was very much developed, these scripts in context with participants. And you could imagine that it could trigger other interventions like pill boxes and the kind of the text messaging or other adherence interventions that was on that slide. It could also put you in differentiated service delivery, but everything is about, at least in our group, not contingency management, but motivational interviewing.
I have a question from the chat. And this, I think, relates to a couple answers ago, but who's taking dolutegravir monotherapy? Is that being used in sub-Saharan Africa?
Yeah, no, it's such a good question. No, unfortunately, that was not really. There are still some pockets, I guess, in Europe where there is more dolutegravir monotherapy being used. I think we remember from a bit ago some of those dolutegravir monotherapy studies. Certainly dual therapy isn't approved. Dolutegravir 3-TC is approved, but I agree. I think that the context of the question is people shouldn't be on dolutegravir monotherapy, and they shouldn't. It's not a completely airtight drug. It's just not. I mean, it's great drug, highly potent. INSTIs are great, but we can't ever have it on a post and not have it with a friend.
Great. Dr. Nasser, would you like to ask a question?
Yes, thanks, Monica. Very nice talk. My question's more technical. What's the affinity of the antibody to the tenofovir?
Yes, I didn't have time to go over all the formative work that we did, but it's very high, and you can't actually have a test where the antibody isn't both highly selective for tenofovir and also not highly correlated with its drug levels, highly correlated with LCMS/MS. So those 4 studies that we've published really went through the usual work that one has to do with the lateral flow assay to ensure that it was highly selective for tenofovir, doesn't pick up other compounds. So if you have a positive test, it's because you're taking tenofovir. It's not because you have DNA in your urine, which you do, because it doesn't pick up adenosine. And then also, it also has a very, it has both a high specificity and high sensitivity for tenofovir, and that kind of work was done by comparing ELISA quantification with LCMS/MS quantification, which is again the gold standard of how you monitor drug levels. So all that careful work had to be done, submitted to the FDA prior to being able to get what is called IDE, or investigational device exemptions, for all the studies that we've been performing. So we also submitted those regulatory and that formative work to the WHO to get a letter of support for our randomized controlled study proposal, which just reviewed well in peer review.
Thank you. One more thing. I'm just wondering if you are aware of anyone who used the reverse transcriptase itself to capture the drug in the urine, since already the tenofovir has high affinity to this protein. So instead of, for example, spending years to develop the antibodies, use that protein that will characterize to capture it.
So to actually look at the viral reverse transcriptase.
Yeah,
protein.
because it's already has high affinity to tenofovir.
Yeah, that's really interesting. That's a really interesting question. I mean, in a way, it's kind of like doing a viral load. It's really looking for, by definition, if this antibody has high affinity for tenofovir, then we should be able to detect reverse transcriptase in the urine. That's a really interesting thought. I mean, I think at this point, just doing HIV viral loads is the most efficient way to look at virus, but that's really interesting, and I'll think about possible ways to exploit this antibody for that. I like that.
Thank you.
Thank you.
All right. I have kind of a conceptual question, and I haven't thought it out well, but I'm interested in your reaction, which is obviously you're really talking about how the context of the prescribed regimen is a big part in the sort of the interpretation. But I wonder, like, are there any public health monitoring benchmarks that would be meaningful, or is this solely an individual, like an individual kind of result? So if you aggregated these results from clinics, is there something that should be monitored?
Well, that's a really interesting question, because the only thing that I can really think of to answer what you just asked is that there's going to be an abstract at CROI from Adrian Shapiro at the University of Washington using our urine test, where the question was surreptitious ART use. And there's various studies in which you'd want to know about antiretroviral therapy use. Certainly in the context of an acute treatment interruption in a cure trial, you do want, the participant off ART, because you want to see, the effect of the cure intervention. So you could imagine using the urine tenofovir test in aggregate in that case to look for surreptitious ART use. In the case of Dr. Shapiro's study, she was looking at a large study of TB in people living with HIV in South Africa, and found that there was a surprisingly high rate of taking ART and not reporting it for a variety of reasons. And I don't think that she's done the qualitative work to figure out why. This was just an initial description. And so that will be at CROI, but it was very high. It was over 15% surreptitious ART use. So it was really interesting, and I think it will get some attention there. So I can see that the urine test being used in aggregate in that kind of setting where you're like pooling large groups to say, is there PrEP use or ART use that we don't know about? There's a study that has been done I actually see her on the call, I believe. Preeti, I believe you're on the call from New York. Who, yes, Preeti Patella had looked at in aggregate samples of plasma from STD clinics in New York. Could you see if people were taking at least plasma tenofovir, because we did the plasma levels for that study, but so to ask about PrEP use in aggregate in kind of pooled samples from STI clinics. So there, I think there are a number of study designs that lend itself to looking at pooled samples and then bringing it down to the individual. So I think these are great study ideas. Some of them have been looked at, but there's much more to study with this urine test. I will say, anyone who's interested in this urine test in their studies, please contact me, because we really have been trying to give it out to groups who have good research ideas to keep on studying it.
Great. So we have time for one more question, and Dr. Go has joined the room here and can ask directly, and then I'll wrap things up. So over to you.
All right. Well, thank you, Monica. This is Yan. I really enjoyed your talk, and I'd like to know, have you tested the effect of a POC urine test only without the counseling? Say if we send the test to participants and to have them test by themselves, do you think that only can improve adherence? Thank you.
Yes. So I do think that there's something about visually seeing there's something about a visually accessible test, yes, no, that can motivate people. And we do have a study that's going to launch using the urine test in a light study context. This is with Dr. Matt Spinelli and others at UCSF, but other places around the country, which is to send everything about the light studies through the NIH is mobile care, and so, remote care. And so the idea would be to send people the urine test and see if it's just positively motivating for them, internally positively motivating to have a positive urine test, and then report that urine test back, or at least take a picture of it and upload it to the study. So I think it really depends. I'll say that I could see how it could be motivating even without a counselor talking to you about it. There's something very positive. A lot of women in Voice, actually, when plasma tenofovir was monitored, said it feels good to know that the drug I'm taking, this is in qualitative analysis, is in my system.
Great, thank you.
That's really potentially interesting as an intervention, just to see if you provide devices, does that actually increase either real or reported adherence in different populations? We are at the end of our time. And so I want to first just point out that Alberto has posted his email address in the chat. And if you want to join the listserv to be notified of future AFP webinars, please reach out and do that. We'd love to have you join us regularly. Thanks to all of you who have joined. The recording of this presentation will be on the Harvard CFAR YouTube channel and the Emory website. Many thanks to Dr. Gandhi for a really just stimulating, thought-provoking presentation, but also for your leadership in this work and moving it forward. Our next presentation will be on February 5th, and we'll send out a full formal announcement, but we'll be presenting about some of the public PrEP resource data resources on AIDSview, and have some examples of earlier career investigators who've used those data who will do some short presentations. So please join us for that. Again, thanks to all you, thanks to Dr. Gandhi, thanks to my co-conspirator here, Dr. Mayer, and I hope you all have a great afternoon.
Thank you so much.
Thank you.
Thank you. That was wonderful.